Welcome to this series on urinary system pathology. Today we'll be talking about renal disease. While we are learning about renal disease, I do want you to keep in mind that there is a lot to know about all of these diseases. For the purpose of ultrasound, I think you need to narrow down what is important to know about these diseases. So first off, you should have a rough idea as to what that disease is causing or what it's doing. You should also have a pretty general idea of what the renal tissue will look like when this disease is present. And then lastly, possibly who it affects or maybe some other side effects of having this disease. Pull out the really key things about each one and stick to that, because again, there's 7, there's 8 of them that we need to cover and how they look like on ultrasound. So to make sure that we are kind of focusing in on what group or what family, what sticks out about these diseases, there's 2 things that we kind of know about renal diseases. And the first one is that there are a handful of diseases that are going to produce general cortex increased echogenicity. So the cortex or the cortical tissue of the kidney is going to be increased in echogenicity. And we know this is most likely because there's more collagen and fibrous tissue deposited out in the renal cortex. So then listed underneath this are a bunch of diseases that make the cortex a little bit more bright. Now, you don't need to know all of these diseases because we're only going to cover the 8 that we talked or listed on the previous slide. But there are a handful of diseases that make that cortex a little bit brighter. So that's one thing that can happen in renal parenchyma disease. The other thing is that we start to lose anatomical detail in the kidney. So we start to be able to lose the ability to distinguish the cortex from the medullary area. So they all just kind of start to blend together. It's hard to say which level is medulla versus the cortex of the kidney. And then again, we have a handful listed. What I want you to know though are the 8 diseases that we're going to talk about. And I've created this chart. I think this is a really good example of some other things that you can do for other pathology. If you find a family of diseases, list some really key factors of them, and then make charts for yourself in which those diseases land, where they land in that chart. That might help you just to kind of make sense of everything that we've been talking about. So feel free to copy this chart down, print this out to help you understand a little bit more. As we go through all of the details about each disease at the end, I encourage you to refer back to this chart to kind of see how all of it makes sense a little bit more. Also with this chart, I think it's nice to point out, at first we have AGN, AIN, lupus, and AIDS. Those all create echogenic kidneys. So maybe you can come up with some sort of like Aunt Alice likes apples for echogenic kidneys. And then sickle cell sticks out as the decreased echogenicity. It's the only one that we talk about that causes decreased echogenicity. So think of different sayings that you can help to memorize these. Think of, make these charts. You can do this for any pathology group of any organ. So we're going to start with acute glomerulonephritis. Breaking down the term again, acute means sudden onset. The glomerular refers to the glomeruli of the kidney, and that's part of the whole filtration process. And then nephritis is kidney inflammation. So this is an inflammation of the glomeruli. Basically what happens though is that the elements of the glomeruli start to die off. They start to necrose. And when that happens, it starts to affect how the whole kidney functions. So the blood vessels start to get wonky, the tubules aren't working anymore, and then remember that interstitium is the area that kind of holds all of this. That area starts to get affected as well. So what ends up happening is that this results in really poor functioning kidneys. The kidneys just don't work anymore when the glomeruli stop working. And whenever your kidneys stop working, then you start to have a backup of fluid, and that can produce peripheral edema. So again, acute glomerulonephritis, know that it's just kind of like the death of the glomeruli. Clinically, these patients are going to have nephrotic syndrome. They're probably going to have hypertension, that's high blood pressure, and then anemia, which is low red blood cell count. So here is acute glomerulonephritis. This again falls into the echogenic kidney category, and it also falls into the enlarged kidney category. So the kidneys are going to look larger than normal, and they're going to be more echogenic. And again, we always compare our organs to one another. If we know we have a relatively healthy patient that should have a normal, healthy liver, then we can compare the kidney to the liver for the echogenicity. Our next pathology is acute interstitial nephritis. So now this is acute, sudden onset, interstitial. So this is the interstitium of the kidney is inflamed. This is going to be more typically associated with other diseases in the body, most likely scarlet fever or diphtheria. Diphtheria is something that we get immunized for now, so that's probably going to be less likely in the United States. Scarlet fever isn't very common either, but sorry, I had something in my, but it is still a possibility. The other thing though is that we can see this happen as an allergic reaction to certain drugs. So the kidneys just kind of freak out. Trying to think, ibuprofen is like, not that it's going to cause this, but ibuprofen is a drug that is processed mostly by the kidneys, where like Tylenol is processed by the liver. So if you have a drug that is more filtered out of the system by the kidneys, they could have a severe reaction to it, and this acute interstitial nephritis could be the end result. As far as symptoms go, these patients are going to have uremia, proteinuria. So uremia is, I believe, nitrogen in the urine, protein in the urine, blood in the urine. Then they're probably going to have a rash, possibly a fever, and then eosinophilia as well. Eosinophils are another type of white blood cell. So here is an image of our acute interstitial nephritis. Again, this is going to be enlarged kidneys, and they're going to be more on the increased echogenicity side, but they're actually going to look kind of mottled too. They're going to have a very heterogeneous appearance to them, but they're going to appear, for the most part, brighter than usual. Specifically with acute cases, when the disease is active is when that kidney is definitely going to be a little bit more echogenic. We find that after the kidney is healed and the active disease is not present, there tends to be a little bit more of a hypoechoic appearance to the kidney, and that's mostly because there's a little bit more scarring through the kidney. The kidney is trying to heal. Lupus nephritis. Lupus is a systemic disease. Nephritis, again, inflammation of the kidney. So lupus is a systemic disease that's an autoimmune disease, and it causes issues with the red blood cells in the body. And the red blood cells have a lot to do with the kidneys. They need to get filtered through there. As far as patients who are more likely to have lupus, it's going to be women, and it usually peaks somewhere between the ages of 20 and 40. And half of these women are going to have some sort of issue with their kidneys. So lupus quite commonly kind of attacks the kidneys. Some other things that happen with lupus nephritis is, again, blood in the urine, protein in the urine, high blood pressure, and one that sticks out on this one is renal vein thrombosis. And then, of course, the kidney is not going to function as well either. So here's an example of our lupus nephritis. And now we've got a kidney that's very echogenic, but lupus nephritis kidneys tend to be on the smaller side. They're very atrophied. So AGN and AIN, enlarged echogenic. Lupus nephritis is our first small and echogenic. Acquired immunodeficiency syndrome, or AIDS, causes a lot of systemic problems as well. The kidneys are not out of reach of AIDS. What ends up happening is that it kind of allows other diseases to set in. So we can see acute tubular necrosis, nephrocalcinosis, interstitial nephritis, or focal segmental glomerulosclerosis. Again, lots of ones. Actually, I think we do talk about all of these except for that last one. I still have something in my eye. Anyway, sorry. So AIDS just kind of makes the kidney a little bit more susceptible to developing these other diseases. So what ends up happening is that the parenchyma becomes echogenic, and typically we'll get either normal to enlarged kidneys as well. So AIDS, because it can lead to other diseases that we've already talked about, we're going to see similar reaction in a patient with AIDS that ends up getting those diseases too. Sickle cell nephropathy. Sickle cell is a blood disorder, and typically our red blood cells are disc-shaped, Well, sickle cell nephropathy, or sickle cell in general, it causes the red blood cells to become kind of a crescent moon shape. And our body doesn't really know what to do with those. They tend to be a little bit stickier. They get hung up on things. They can't carry the nutrients the same way that the disc-shaped red blood cells can. And of course, our kidneys filter our blood cells so it can pull out the toxins and transfer things around, right? So now if we have cells that can't do what they're supposed to do and can't fit through the filtration process in the kidneys, then they're going to start to get globbed up there and they're going to start to cause problems. So the sickle cell nephropathy does commonly affect the kidneys because of the way that the kidneys are built to filter all of the blood. Some of the ways that we see the sickle cell nephropathy affect the kidneys is glomerulonephritis, renal vein thrombosis, and papillary necrosis. And we'll talk about all these except for the renal vein thrombosis, which is kind of self-evident thrombus within the vein. Blood in the urine is very common with sickle cell. All right, so now we've got another disease that sticks out in a different way. With sickle cell nephropathy, in the acute setting of a renal vein thrombosis, we're going to see that the kidney starts to look hypoechoic. All right, so it's going to be enlarged, but hypoechoic. So now we've got AGN, AIN, both enlarged and echogenic. We had lupus, which was small and echogenic, and we have AIDS, which is normal to enlarged echogenic. Now we have sickle cell nephropathy, which is enlarged, but hypoechogenic. Okay. We do see after everything heals and the sickle cell neuropathy kind of dies down, we start to get into a subacute cases, and at that point the kidney can become a little bit more echogenic. But when the sickle cell neuropathy is full on, we're going to typically see a picture like this where the kidney is large, looks edematous, and on the darker side. Hypertensive nephropathy is uncontrolled hypertension that tends to lead to progressive renal damage. So again, our kidneys are really a big player in how the body handles blood pressure. And if we are constantly at high blood pressure, that can actually start to damage the filtration system in the kidneys. There needs to be a very gentle filtration system, and that hypertensive state all the time really puts a lot of pressure on the kidneys, and because of that, it starts to damage the filtration system. So with hypertensive nephropathy, we are going to see kidneys that are going to be a little bit smaller. We're going to start to see a little bit more issues with the collecting system becoming inflamed. We might see some infarctions come in because there might be some blockages due to the blood. And then bilateral small kidneys can occur, and that's going to be more secondary to end-stage disease such as hypertension, inflammation, or ischemia. So on this picture, we have on the left side, the one labeled LK, the left kidney. This one measures 8.8 centimeters. So it's a very tiny kidney. You can see that the parenchyma is starting to become thin. And in general, this is a response to hypertension. On the right kidney appears to not be affected by the persistent hypertensive nephropathy. So we actually see a relatively normal kidney on the right. Papillary necrosis is another disease that can affect the kidneys. And what happens is that the papillary piece of the pyramid sits right at the apex, right at the top of the triangle. And those become destroyed and start to die off. Things that tend to happen, or things that tend to lead to papillary necrosis, are going to include some drug abuse. Sickle cell disease can cause it, diabetes, obstruction of blood to the kidneys, so like a renal artery stenosis, maybe a pyelonephritis, again, that's infection or inflammation of the collecting system, and then renal transplant recipients tend to go through papillary necrosis. It's a very common thing. So what ends up happening is that the apex point of the medullary starts to die off, it starts to necrose, and what they think it mostly has to do with is how much blood is getting into the kidney. Again, the kidney is very, very sensitive to any changes within the body. And if the kidney does not get enough blood, then it can't do its job and parts of the kidney start to die off. And the papillary just happens to be very, very sensitive to it. So with kidney transplants, this normally will develop within weeks or months of the transplant. Again, one of the biggest reasons transplants fail is because of the blood supply. And this is one of the first things that we'll see. So here's a picture of a kidney with papillary necrosis. What ends up happening is that at the pyramids, as the papillary starts to necrose, they're going to become cystic. So right where the pyramids are, we expect to see little cystic spaces. And those cystic spaces tend to be round or triangular. And usually we see those cysts right at the border of the cortex and the medullary. And then our last disease that we need to talk about is renal atrophy. And so renal atrophy can be the result of a lot of different diseases. We've already talked about hypertensive neuropathy that can cause it. Renal atrophy is just kind of the body's response to some disease that's really affecting the kidneys, most likely not getting enough blood to it, and so it just kind of starts to die off and doesn't really want to work anymore. What ends up happening is the intrarenal anatomy is typically preserved, so that's going to be your medullary and your sinus. Those are typically preserved, but we're going to start to lose a lot of that cortical tissue. Another thing that we see quite often with renal atrophy is renal sinus lipomatosis. Now remember, we talked about this as a renal variant. It is something that we can see in very healthy kidneys, but it is also a response to renal atrophy. Here is an example of renal atrophy. It looks like maybe it's affecting both kidneys. So you can tell that both sides are a little bit smaller. They're smaller than what we would expect. And then we have an enlarged renal sinus on both kidneys. We can see that here and here. And so the sinus is very enlarged. It's echogenic because there's a little bit more fat in it from the sinus lipomatosis. And then the other thing that we see with renal atrophy is a thinning renal cortex. Remember, a renal cortex in a healthy kidney should measure over 1 centimeter. In renal atrophy, we'll start to see it fall below that 1 centimeter threshold. Here is another example of renal atrophy. The kidney on the left picture is starting to look a little bit more heterogeneous. It's small. We're starting to lose some of that tissue differentiation through here. Again, we have a very enlarged sinus and thinning cortex. The same is true for the picture on the right. The renal sinus lipomatosis has become very apparent, very large, and then we have that thin cortex surrounding. So that brings us to the end of our renal disease section. Again, there's so much more information that you can know about all of those diseases, but what we really want to focus on is what is the name of the disease, basically what is it doing, and what does it look like on ultrasound. There's tons of labs that overlap with all of that. There's nothing that's super specific to any of it. So pull out the key parts that you can to help you remember those key things that we need to know about each disease. Our next section will be about renal failure.